Welcome to Healthcare IT Today. I'm John Lynn, together with my colleague and friend, Colin. The world of technology and healthcare, ever-changing in new and novel ways, and that's why we love this stuff. So join us as we discuss the latest healthcare and health IT news, meshed together in new ways which help generate ideas and new perspectives. Plus, we'll have a little fun along the way. Today, we're going to be doing a Heard at Conferences version of Buy or Sell. And be sure to follow the show on social media at the hashtag HITSM and our personal accounts at TechGuy and at Colin_Hung. Plus, check out our 20 years of health IT content at healthcareittoday.com. Colin, have we set a record for a number of conferences attended in a 3-week period?
We might have.
It's a personal best, I think. We've been to quite a few.
We did go to quite a few. I mean, ever since Vive, we haven't been off the road really.
It's true. Yeah, I mean, it's a good thing, right? It makes sense at Healthcare IT Today. We're getting invited to so many user conferences to cover them and do videos at them and to feature their customers, which is really fun. I think we both agree user conferences are some of our favorite because you hear what's really happening on the ground and with the software, and even you have plenty of conversations that don't even relate to the software, just industry ones. So it's really insightful.
Well, that's why we thought this one would be kind of fun. So instead of doing our regular buy and sell where you and I offer our opinions, we're going to do a buy and sell where we're going to talk about what we've been hearing. So this is not our opinion. This is just things we've been hearing from all the attendees and all the people we've been speaking with at conferences. So got to go right to the first one, John. Are healthcare IT budgets shrinking? Are you buying or selling that?
I mean, I'm kind of selling that because shrinking doesn't begin to describe what's happening. I think it's much worse than that. Like, at a minimum, they're frozen, even at the largest organizations, but most of them are not just having shrinking, they're having to take major cuts to what they're doing. They're having to just not even, basically stop doing some IT projects, certainly not buying new projects unless, you can sneak it in there if it's maybe a value-based care IT project in the sense of like, hey, there's no cost to do it. It's just, that it's some commission off of savings or some things like that. But yeah, I mean, for what I hear from most organizations is that their budgets are not just shrinking, but getting pretty massive cuts, even headcount cuts in some cases. And that's when it's really bad, is when the headcount starts going.
Yeah, I'm definitely buying this. Certainly a lot of the CIOs that I've been speaking to, a lot of the executives at vendors that I've been speaking to, everything is just getting postponed. So definitely no new projects are getting kicked off. The only projects that seem to be still happening are ones where the savings are just very substantial, like 6 figures or more kind of thing. And almost within the next 3 months, you get those savings. Those are still going forward, but anything else, anything that was nice to have, it's on hold or has been cut or it's just been postponed indefinitely. So I haven't heard of too many like headcount cuts yet. That's not something I've heard, but definitely been hearing it from the vendor side that just things are not moving forward right now. So
yeah, I heard one CIO say that if it doesn't impact the P&L in a positive way, we can't even consider doing it, which is really hard as a CIO because the CIO is being told, hey, your budget's frozen, it's cut, whatever, it's shrinking. And then, but by the way, what's your AI plan? And so they're like, we need an AI innovation plan, and yet you have to do it with a smaller budget. So the pressures on them are pretty extreme.
Yeah, no, and you're absolutely right in terms of P&L impact. Which means, unfortunately, there are some areas where you shouldn't be cutting, but it is on the cutting block. Things like cybersecurity, right? Like that doesn't really have a P&L impact tomorrow. It could potentially have a very big P&L impact down the road. Yeah, but it's an insurance policy, right? And so right now, when you're in this mode where we've got to meet a certain budget number, Unfortunately, that kind of insurance doesn't get paid. So, yeah. So definitely, I'm buying into it. It's definitely shrinking. It's pretty bad out there. But that's not to say there's nothing happening. Like I said, like there are projects going forward as long as it's very, very clear that there's real dollar savings, not virtual.
Mhm.
Like they're not interested in saving 2 minutes, right? They're not interested in saving zero point 0.6 of an FTE. Like it's got to be, like, oh, I can cut like 5 people, or I can, I don't have to spend Y where I was spending Y. I can now spend X, and it's much lower than Y, right? Like that. Those are the real hard dollar savings that people have that are really being sought after right now.
Yeah, you have a reduction of claims denials. That's a pure profit one, right? You can cut your costs with some of your legacy vendors as a savings that has a direct line to it. There are some other ones, and I'd say this is the other trend you see happening in health IT. Is it's not like, hey, by the way, we're not spending, so you don't have to work because we're not having new projects. What we see people doing is you double down on the vendors that you already have. And every organization has plenty of health IT vendors, and so they're going to those vendors, and that's what we're seeing happening too on the cost side. They're going to them and saying, "Hey, what can you do to help us? We're in this kind of financial situation." But then they're also saying, "How can we collaborate together to improve what we're doing and leverage your system better to create better outcomes? Even though we can't spend more money, we can optimize the current systems that we have." And maybe leverage updates that have happened that we didn't really leverage before. So I think that's the other trend that's happening with organizations, is saying, well, could we get more juice out of the existing systems that we have?
Well, so then on a related note, John, are you buying or selling that vendor consolidation is still a high priority for CIOs at the moment?
This is a hard one for me because that idea of consolidating vendors, having fewer vendors, is an overarching concept that most organizations want to do. And I just heard a great example of a communications vendor that consolidated 5 other systems into one. And there are these platforms, where they can replace multiple vendors. So I think there are amazing opportunities like that. The challenge with it, and that's why I'm buying and selling it. Is that cheating? I don't know, but like I'm buying it for a lot of organizations where there's still opportunity, but I'm selling it because a lot of organizations have already done the consolidation, and there's not more value to be gotten out of it because they consolidated so much already. So I think that's the challenge, is that many of these organizations have done the consolidation, and so therefore there's just not the same opportunities to be able to do that. Now, will they acquire more systems and then you have to do it again? I think that's going to continue to evolve, but I don't think we're seeing quite as many, quite as much consolidation of healthcare organizations right now as we saw over the past maybe 3 or 4 years. I think we're seeing a bit of a slowdown there. And I don't know if that's directly related to some of the budget pressures and revenue pressures that organizations have. There's just maybe not as many attractive organizations to buy now, and a lot of the ambulatory practices have gotten so big that it's not a simple transaction that you just go convince the one doctor, the 3 doctors to sell to you. So I don't know if that's going to adjust it. We'll probably have a couple of really big bang ones that happen over the next year, but the fact that there's not as many, at least it feels like it to me, there's not as many, maybe that's making the consolidation opportunity less.
Yeah, I definitely agree that the bang for your buck on consolidation may not be as much as it was in prior years, because you probably knocked off and consolidated the big dollar ones already. But I'm buying into this because a lot of the CIOs I've spoken to, especially at HIMSS, but at some of the other conferences as well, the user conferences, they're definitely on the hunt to say, if I don't have to go and buy something new to achieve what my operations teams want, meaning I already have a vendor and they have a module that does this, I'm going with that, even though it only provides 60% of the functionality, because it's more likely to be free or near free, right? Like even if I can't, even if it costs money, I can probably lean on my current vendor to give me that module for the next 7 months at $0 to pilot it or to try it. And then if it works and we can show the value, then I'm willing to pay the X or Y. Right. And because that vendor is obviously financially incented to do this, they'll agree to that because it's an add-on module. It's not their main modules. So I've definitely heard more of these types of stories relating to AI on the periphery type stuff, but also things like reporting, like patient communications tools and those kinds of things. I just see a lot of more people going, well, yeah, although, we would love to use vendor X because they're best in breed and they do all these fancy things, I can't afford that right now. So I'll go with this vendor over here who has something, and I'll just use people power to kind of slash it together.
Yeah. I mean, you're making a really good point about the EHR vendors in particular and how expansive they're being in their products and what they offer. So that is the other thing that drives this kind of vendor consolidation. I mean, I saw that firsthand at the ECW, eClinical Works Health Center Summit. The number of announcements into pharmacy, into behavioral health, even into the acute care space and into, like a number of areas, the call center, et cetera, right? Like all of those could have been products. And now you can just get it from ECW. They announced Helo IQ, which is quite frankly, a competitor to the Open Evidence and the UpToDate and the Doximity, et cetera, et cetera, et cetera. I think there's a few others out there that are doing it right. And now I think those eClinical Works users are going to say, oh, do I need that separate solution? I could just get it from ECW, who I already have a contract with. It can, maybe some fun financing approaches, right? Where they roll it into the existing contract, call it an update, and the CFO can't argue with it, right? Like, I don't know if that's what's really happening with organizations if people do that, but you can see, to your point, a lot of the consolidation and getting rid of some of those other vendors may be just, hey, Epic's already doing it. Like Epic has that big roadmap as well, and they can offer a lot of those solutions. And so the same thing happens with Epic as I described with eClinical Works.
Yeah. Yeah. And I think, again, existing incumbent vendors are incentivized to do this. So, I think a few of them might be on the hunt right now to look at expanding their footprints. But also there's a mental tax to having multiple vendors, right? And as IT teams shrink, not because they're actively shrinking, but maybe they're not replacing somebody who's left, right? With a smaller team, you don't want to be dealing with that many vendors. It's just that much more tax on your people. So consolidating makes sense. It just helps you to focus on the things that you really want to focus on. So I definitely hear this. It's not as overt as maybe, in the past where people have 17 vendors and they're trying to get to 5. I don't think I hear too many more stories about like, I need to get down from 5 to 1, right? They've already squeezed out a lot of that juice, but it definitely is happening when it comes to new things. They're not looking anymore necessarily to just buy whatever's off the shelf and the latest and greatest. They are looking at existing vendors to say, well, what do you got that maybe I could use?
The interesting thing is, are we starting a new cycle of that? Are we going to adopt 30 AI vendors, and then we have to go and now, we're starting that cycle again. Now I got to consolidate it and get rid of a bunch of AI vendors. We might.
we probably are, John. We probably are. And hey, if you're just tuning in, you're listening to Healthcare IT Today with John Lynn and Colin Hung. Today, we are comparing notes on the trends from all the different conferences that we've both been recently attending and deciding whether or not to buy or sell into some of the trends. So, John, this next one's a doozy. Value-based care is the key to rural health success or survival. Are you buying or selling this?
Ooh, this one's a tough one. I spent a lot of time at the garage talking about value-based care, and Navina talking about value-based care and their efforts to really enable it. And there's a compelling story there for how rural health can benefit from value-based care, even though it's a challenge. Because if you're a rural health organization and your population's 55 people, that's hard to do value-based care on 55 people. That doesn't wake up the insurance company to want to work with you. But they're consolidating and working together and doing contracting in certain ways that is allowing them to benefit from it. So I guess I'm selling the premise that value-based care is the key to rural health survival. I think that it's an opportunity for rural health, and many rural health organizations could benefit from participating in value-based care and getting those dollars that they couldn't get in another place. But I'm not quite sure that their survival is dependent on you doing value-based care. I think there's other factors that come into play, and reasons why they could be successful even without value-based care. The pressures are incredible. Like, sure, there's a $50 billion rural transformation fund that's, and that those dollars are coming to them, but there's estimates that it could be close to $1 trillion of cuts coming their way from the one big beautiful bill, which I'm pretty sure they don't call it a beautiful bill if it's $1 trillion of cuts. But so there's a lot of pressures on them. So I think is it a tool in their tool belt that they should look at and consider? Yes. But I think there's a lot of things they probably need to do beyond just value-based care to ensure that they survive and are successful and really thrive in the current environment.
Yeah, I am definitely selling this one. I've heard this mentioned a few times by various presenters, various people in hallways to say, hey, well, what about value-based care? Isn't this such a great thing for rural? I mean, I think value-based care is a good thing no matter what kind of care you're providing, whether you're rural or urban. I think value-based care is a good thing. But, we don't hear a lot of stories about financial success through value-based care. Most of the stories I'm hearing about value-based care is, hey, this is a nice add-on, a nice add-on program to something else we're doing, like in the fee-for-service world or some of the other things that they provide. So, and rural healthcare has got so many challenges, right? Like, it's not just a revenue stream problem. It's a staffing problem. It's a, not understanding your population and not even having coverage problem, right? Like, there's a lot of other problems where I don't think value-based care alone solves, to your point. But in addition, I just don't think they have the populations where this works very well. Right? Like, if you think about rural-based care, a lot of it is very acute in nature because that's why they're seeking care, right? Like, not a lot of people, like these, traditionally in the rural-based settings, are seeking care for common things because they found other ways to get around it. They found their own ways to deal with it because they've always had the problem where they've not had a hospital ready at hand, right? Or that many specialists ready at hand. So they've made do and they do other things. So anyway, where I'm getting to is, I don't think that this is the hype. I'm not buying into this hype that value-based care is the answer for rural health.
Yeah, I mean, I heard one person say that rural health already practices value-based care because it's their neighbor and their, their friend, et cetera, that they're caring for. And so in some ways it aligns well because the doctors truly do want to do what's best for their community because they're friends and neighbors and their kids go to school together, et cetera, right? So in that way, it aligns really well. Some of the challenges, like the Garage pointed out to me, there's a great interview coming out shortly that I just did with them, where they talked about the challenge of rural health doing value-based care is they only provide 50% of the care to their patients. 50% of the care is happening in the big city that they traveled to 2 hours to get the care from the specialist that wasn't available in the rural, and now they got to be accountable for the care that they're not even providing. And so having the data there and being able to do that is really important. And that's why organizations like the Garage, even Alidate is doing a lot of that, helping them understand where else is care being given and can I get the data, back and, the data interoperability to understand that, hey, they did, they were going to a concert in the big city and they got an incident and now they got an emergency room visit. Like, having that data available is so important. So there's opportunity there. There's a culture there that fits, doing value-based care, but they're under a lot of pressure. So I think they're going to need a lot of help from a lot of different directions to be successful.
Totally agree. All right, let's get to the last one, John. Are you buying or selling that healthcare AI will not replace people in healthcare?
Well, I mean, do I want myself replaced with an AI? It's interesting, right? Like, I think we would all agree on one premise, which is we all want AI to replace the things we don't like doing in our job. And we all have things we do in our job that we don't enjoy that much. And so that's actually, I think, the premise that I hear most. And I heard it, by the way, I heard this line over and over at conferences. Healthcare AI is not going to replace the people. We're not firing people. We're doing it. And in many ways, it feels like a PR stunt. Like, hey, if I tell you it's going to replace people, that's going to get some kickback and we're not going to be able to adopt the AI. And as a leader, that's bad because I need the AI to replace some people so I can afford to do it. Now, are people doing it in a very thoughtful way? So the attrition happens, the people leave on their own, and now I just don't replace them because the AI is making it possible. I think we're seeing a lot of that as well. So I guess I'm selling that it's not going to replace people, in the sense of it's going to replace people's jobs, right? Like, I mean, how many people do we have, driving horses right now? Like that job is gone, right? We don't have any typists that are taking notes at meetings, right? Like the only place that still exists is in the judicial system where there's a court reporter, which anyway, that's a whole other topic for another day. That should be replaced too, right? Like, and so like there are jobs that are replaced. When you get in an elevator, is there a bellman there pushing the button in the elevator for you? No, they're not, right? So jobs will be replaced, but I think a lot of it is a good thing because the jobs that are being replaced, those people are going to be upskilled to something better. And so I think, in the long run, it's going to work out fine.
So I'm buying this, but I may not buy this a year from now. But I'm buying this right now for two reasons. I don't think anybody believes that AI has progressed enough where it can replace any clinician at any level. So definitely on the clinical side, I don't think anybody's comfortable yet to hand over the keys to a clinician, to an AI clinician.
We're not, at least from a liability perspective, from a knowledge perspective.
Exactly. Like from a liabilities perspective, from a PR perspective, no one's ready for that. And even on the administrative side, I think that AI is not replacing anybody because there was a shortage to begin with. So what's happening, I think, is that we're not getting rid of people because we're adopting AI. We're just not having to hire 10. We only need to hire one now, right? We only have to look for one claims person because I was able to use some AI to help me with the claims process, to streamline it or do some things. Instead of hiring 22 call center agents, I only need to hire 5, right? Because I'm using some sort of AI to triage the calls. So I think there was a shortage of people already, and that's because healthcare has not traditionally paid very well for these types of jobs, comparatively speaking to the financial world and other worlds. So AI is helping to allow people to take on more work without burning them out. So I think that's the stage where AI is at. So I think it's legitimate that people are saying, yeah, well, we're not using AI to replace anybody. We've just got this stack of job descriptions that we can't go out and hire because we've been told we can't hire anybody. So guess what? I'm using AI to help the 5 I've got left to make their job a little bit easier. So I definitely think that is what the case is right now for AI.
It's interesting to go back to the health IT budgets. And if you're frozen and you're not allowed to hire more people, but you might be able to hire more AI bots,
Right.
That's a different hiring freeze, right? Or a budget freeze. So that's interesting. I'm thinking about this CEO I heard talk about Hilo Genie, which is the call center agent from eClinicalWorks that answers all the phone calls. And he said, we're not firing people. In fact, we're hiring more people. And then he said something really interesting. He said, but we're using the data from Hilo Genie to know who we should hire. What type of person do we really need to be able to fulfill the thing that the AI agent can't do? And we're getting all of this data to allow us to know who we need to hire, when we need people to work. So it's interesting how the AI in some ways is informing the types of hires that we need to do. And I think that's going to be a trend as well. When you say, oh, who do we want to hire? Maybe we don't need to hire, someone to do data entry anymore, but I do need someone that's good at quality, that's good at workflow, that's good at AI automation and prompting and everything else, right? So you might be hiring a higher skilled person that knows how to do automation, whereas you're not hiring that lower skilled person who is just doing data entry.
Yep. No, I totally agree with you there. I can totally see that. And I heard similar things from, Richard Atkin over at Greenway and VJ over at Ramsoft. I mean, the power of AI and vibe coding and the ability to put together prototypes so quickly now, it's something that they've never had the capacity for before, because it would require junior programmers or a summer intern to do that. But now, you could just, through a little tiny miniature hackathon internally, you could vibe code like a bunch of stuff. It's not obviously production ready, but it's enough to kind of prove the prototype, like, would this work? And then you can put that in front of a customer and get some feedback on it, and then go ahead and do the real development. If anything, what I've been hearing is that the one hire that they don't have to do because of this is they need fewer product managers. Right? Because, product manager used to be the ones where they had, they sat between the users and tech and did all the requirements and everything. And now development can happen so fast, they can just code the thing and then just put it in front of them. And then the roadmap is jumbled now because you're just coding to these new modules that have come out where you've gotten really good feedback from. So anyway, where I'm going is the same argument I was making before. It's not that you're cutting your existing staff, but you're now using AI to enhance what they're doing and increasing their output, therefore allowing you to grow without having to add people in a linear fashion like you used to. So I definitely think that's true in healthcare.
I mean, just real quick, it's interesting how the IT companies are going through these massive cuts, right? We've seen it from a wide variety of them. 10,000 people laid off, 20,000 people laid off. And you look at that and I was like, we haven't really seen that on the health IT side. And a lot of the conjecture, we laid off 10,000 people because AI is taking their jobs. Well, when you dive in a little deeper, you're like, no, actually, those companies were just bloated and had people doing jobs that weren't very meaningful and weren't impacting the business. So let's use AI as the excuse for why we're cutting jobs. But in reality, it was like, no, these are bloated companies that probably needed to cut back because they had people doing jobs that weren't actually impacting the organization and the users. So we aren't seeing that, though, so much in the health IT world, at least not yet. I haven't really seen any of that other than some that are tech and health IT, right? The right. Microsofts and Oracles obviously are in that category. But, so it's interesting. Will we see that kind of evolve as well?
That's very true. I agree with you there. I've not heard any CIO at a vendor talk to me about massive cuts coming or that, they're looking at maybe downsizing staff. It's still all full ahead, right? They've got so much work, so many things to do. They're just pushing ahead with it. Yeah. But, well, hey, John, we're at the end of another episode. So thanks to all of you who tuned into this episode of Healthcare IT Today. You can find more details about our show by checking out the programs page at healthcarenowradio.com. And please share your voice and engage with the community at healthcareittoday.com and on social media using the hashtag HITSM. I'm Colin Ahung, along with my friend and Health IT collaborator, John Lynn. Thanks for listening and have a great week.